Approach to cyanotic congenital heart disease. As you all know, the cardinal features of cyanotic congenital heart disease are cyanosis, clubbing, and polycythemia. Now let's look into the clinical symptoms in detail. The principal symptom of cyanotic congenital heart disease is cyanosis. Now, using the onset, severity, and pattern of cyanosis, certain possible diagnoses can be entertained. Let's first take the onset of cyanosis. Very early presentation in newborn with cyanosis occurs in transposition of great arteries, tricuspid atresia, total anomalous pulmonary venous connection, truncus arteriosus, severe type of tetralogy of Fallot, that is all T's, and in pulmonary atresia with hypoplastic right ventricle. In slightly older children with delayed cyanosis, you can think of less severe forms of TOF or one of its variants. In adults, cyanotic heart disease in adults can have different pathophysiologies. First, it can occur due to decreased pulmonary blood flow, as in tetralogy of Fallot, and also in non-TOF conditions such as tricuspid atresia, TGA, DORV, single ventricle, all being associated with the pulmonary stenosis, and also in EBSTEINS anomaly. Now, in adults presenting with delayed cyanosis due to decreased pulmonary blood flow, it is more important to consider shunt lesions developing pulmonary artery hypertension with shunt reversal, that is to right to left shunt, and cyanosis, that is Eisenmenger syndrome. You can get occasional cases of cyanotic heart disease with increased pulmonary blood flow, as in unobstructed TAPVC. Rarely, cyanotic heart disease can occur with normal pulmonary blood flow due to abnormal connections, as in pulmonary AV fistula, LSVC2 left atrium. Now let's consider the severity of cyanosis. A neonate suspected of having heart disease who is in shock, profound cyanosis, and acidosis often have ductus-dependent congenital heart disease such as pulmonary atresia, aortic atresia, hypoplastic left heart syndrome, interrupted aortic arch, etc. In general, most severe cyanosis occurs with complex cyanotic heart disease with some exceptions, and usually cyanosis with decreased pulmonary blood flow is well tolerated unless presenting with cyanotic spell. Finally, let's consider the pattern of cyanosis to consider an etiology. Intermittent or stuttering cyanosis, that is, cyanosis at birth, regression, and reappearance later, occurs in EBSTEINS anomaly of tricuspid valve and also in TAPVC and in truncus. Whereas uniform cyanosis indicates right to left shunting at atrial, ventricular, or ascending aortic levels. Non-uniform cyanosis occurs in Eisenmenger PDA, that is, severe pulmonary hypertension and right to left shunt across PDA. It is called either as differential cyanosis or occasionally reversed differential cyanosis. Now, what does differential cyanosis mean? It means cyanosis is present only in the toes, and it indicates that it is an Eisenmenger PDA with normally related great vessels. Now, reverse differential cyanosis means cyanosis is only in the fingers, and it indicates that it is again an Eisenmenger PDA but with detransposition of great vessels. Now, hyperoxia test is done to rule out critical cyanotic congenital heart disease. It is performed by doing a right radial arterial blood gas in air and after administering 100% of oxygen for 10 minutes using a hood. If the saturation PaO2 is more than 300 mm mercury, it definitely excludes cyanotic congenital heart disease. If the PaO2 is greater than 200 millimeters of mercury but less than 300, it is unlikely to be cyanotic congenital heart disease. But note, false negative occurs in unobstructed TAPVC. However, if the PaO2 is less than 100 millimeters of mercury and usually lower, it is likely to be cyanotic congenital heart disease. But keep in mind severe lung disease manifesting with increased PaCO2 and pulmonary hypertension. Apart from cyanosis, patients with cyanotic congenital heart disease have other symptoms also, such as could have had difficult feeding, poor growth, poor weight gain, difficult breathing, frequent respiratory infections, syncope, seizures, and also chest pain, palpitations, stridor, and one must also look for a syndromic appearance. That means sometimes one can look and tell a syndromic appearance. For example, Down syndrome, trisomy 21, patients have atrioventricular septal defect with pulmonary stenosis or can have TOF. In Dye-George syndrome, 22q11.2 deletion syndrome, the patients have truncus arteriosus or could have tetralogy of Fallot or DORV. So now let's go into the clinical signs. Physical examination should be swift and meticulous. See the appearance if the patient is pale, appears dusky, has polycythemia or appears syndromic. Examine for cyanosis and clubbing. Look for tachypnea, respiratory distress. Check the height, weight for physical development. Observe for skeletal abnormalities such as polydactyly, among others. Check the pulse for tachycardia, arrhythmia, volume and palpability. Preferably check the BP in all four limbs. Examine the JVP as it is elevated in tricuspid atresia and in Eisenmenger syndrome, often normal in tetralogy of Fallot. It's quite important to examine the abdomen for the sightedness of the liver along with palpation of the apical impulse to find out dextrocardia and situs abnormalities, if any, and also palpate for hepatomegaly. Now, what is the approach to cyanotic congenital heart disease? Physiologically, we classify cyanotic congenital heart disease as having cyanosis with decreased pulmonary blood flow, cyanosis with increased pulmonary blood flow, cyanosis with normal pulmonary blood flow, and abnormalities of mixing of deoxygenated and oxygenated blood. And finally, one can have combinations. For example, TGA with large VSD, TGA with large VSD and PS, etc. However, the two major significant groups are cyanosis with decreased pulmonary blood flow and cyanosis with increased pulmonary blood flow. Now, this is a very important slide showing the clinical differences between decreased and increased pulmonary blood flow in cyanotic heart disease. In decreased pulmonary blood flow, the classical example being tetralogy of Fallot, it can present at any age, appearing comfortable with cyanosis which can be mild to severe, spotting and cyanotic spells being common, and they are without any feeding difficulties or diaphoresis, and they thrive well with normal weight gain. They do not have recurrent LRI, there is no tachypnea, the heart size is normal, heart failure, tachycardia, S3, S4, etc. are absent. Thrill may be present, systolic murmurs occur, and the chest X-ray shows oligemic lungs and no cardiomegaly. In contrast, In increased pulmonary blood flow, the classical examples like TGA or TAPVC present in neonate and in infancy. Patients appear sick, lethargic and irritable. Contrastingly, the cyanosis is often mild, except in TGA with intact IVS. Squatting and cyanotic spells are uncommon. Feeding difficulty, diaphoresis are prominent with failure to thrive and therefore suboptimal weight gain. Also, recurrent LRI is especially common with shunt lesions. And the patients have tachypnea, cardiomegaly does occur, and they have heart failure, tachycardia, S3, S4 being present, thrill is absent, soft diastolic murmurs occur, and chest X-ray shows plethoric lungs and cardiomegaly. So, by keeping this in mind, you can clinically differentiate a patient in cyanotic heart disease whether he has a decreased pulmonary blood flow or an increased pulmonary blood flow, which aids to arrive at a possible diagnosis. We shall now consider cyanotic heart disease under the three pathophysiological states of decreased pulmonary blood flow, increased pulmonary blood flow, and normal pulmonary blood flow. To begin with, the first major group of decreased pulmonary blood flow. Now, cyanosis with decreased pulmonary blood flow is often associated with pulmonary stenosis, pulmonary atresia, or another pathology of pulmonary artery hypertension. Now, cyanosis with decreased pulmonary blood flow occurs in large left to right shunts, in which later in life, due to pulmonary vascular obstructive disease causing severe pulmonary hypertension, and therefore it reverses the shunt as right to left, producing decreased pulmonary blood flow with cyanosis referred to as Eisenmenger physiology. Now we shall consider this later. Majority of these patients of cyanotic heart disease with decreased pulmonary blood flow is due to pulmonary stenosis, usually have a large unrestricted VSD. Now, this common combination of PS with large VSD in cyanotic congenital heart disease is referred to as Fallot's physiology. In these patients, cyanosis is due to right to left shunt through the VSD. Less commonly, cyanotic heart disease with decreased pulmonary blood flow is associated without a VSD and only PS. In these patients, cyanosis is due to right to left shunt at another level, that is at the atrial level through an ASD. There is a rare group of cyanotic heart disease with decreased pulmonary blood flow without VSD and without PS. In them, usually the RV is very small, that is hypoplastic, with restricted entry of blood into right ventricle. So all the blood gets shunted from right to left at the atrial level through an ASD. Now, Fallot's physiology can be clinically grouped as those with TOAF and those with non-TOAF, such as TGA VSD PS, DORV VSD severe PS, LV type of single ventricle with PS, and pulmonary atresia with VSD. So, to put matters short, in order of importance in cyanotic heart disease with decreased pulmonary blood flow are pulmonary stenosis with VSD, called as Fallot's physiology, which is most common, and then pulmonary stenosis with ASD, and lastly hypoplastic RV with ASD without VSD and no PS, which is not very common and it is rare. Now we will focus on cyanosis with decreased pulmonary blood flow due to pulmonary stenosis or pulmonary atresia, which is associated with a large unrestricted VSD, or as referred to as Fallot's physiology. Now, lesions in Fallot's physiology can be further categorized based on the type of apical impulse. So, RV apex is found in tetralogy of Fallot and in pulmonary atresia with VSD, DORV with VSD PS, DTGA VSD with severe PS, and also VSD PS. Now, LV apex is associated with tricuspid atresia with restricted VSD and PS, single ventricle of LV type with PS, pulmonary atresia, intact IVS and a small RV, and occasionally in left SVC draining to LA. So now what are the symptoms in this group? Symptoms in this group include late onset of cyanosis often after 6 months of life, squatting or cyanotic spells, there is no congestive heart failure, and cerebral abscesses may occur. So clinical examination. How does cyanosis with decreased pulmonary blood flow clinically present? Classical example being tetralogy of Fallot. The JVP is normal or shows a slightly prominent A wave. On inspection and palpation, they have a quiet precordium, a mild parasternal impulse with systolic thrills being uncommon. On further examination, the heart size is normal, that is, there is no cardiomegaly. On auscultation, the second heart sound in majority of patients with TOF is heard as single S2. Actually, the S2 is widely split due to delayed and soft P2, all because of pulmonary stenosis. Most often, the P2 is so soft that it is inaudible to the human ear, and only the A2 is audible as a single second sound. That is why it is heard as a single second sound. Phonocardiogram reveals a split S2 in TOF. However, wide split S2 may be heard in patients with only infundibular PS. In pulmonary atresia, the S2 is truly single due to the atretic pulmonary valve. Murmurs. Auscultation reveals a grade 3 or more ejection systolic murmur arising from pulmonary stenosis. So murmur in this group of patients is from PS. In TOF having VSD and PS, this murmur of PS is inversely proportional to severity of cyanosis. That is, in tetralogy of Fallot with VSD and more severe PS, one hears a lesser pulmonary systolic murmur with more severe cyanosis. Also in malposed great vessels, the murmur is louder than cyanosis. Now in contrast, in pulmonary stenosis with ASD, without VSD, the ejection systolic murmur of pulmonary stenosis is directly proportional to the severity of cyanosis since IVS is intact. Also, it must be remembered that the VSD in this group of patients is silent because it is a large VSD and both the right and left ventricular pressures are equal. There are no flow murmurs and it is an important negative finding. Also, continuous murmurs can occur in cyanosis with decreased pulmonary blood flow, but never in cyanosis with increased pulmonary blood flow. The cause of the continuous murmur in cyanosis with decreased pulmonary blood flow is an associated PDA or MAPCAS. Hence, pulmonary atresia will have cyanosis with continuous murmur, and there will be no ejection systolic murmur because there is no antegrade flow across the atretic pulmonary valve and there will be no VSD murmur. Therefore, if a patient has cyanosis with only continuous murmur, it is a hallmark of pulmonary atresia often. Now the diastole is clear. There is no S3 or S4 and no diastolic murmurs. If chest X-ray is a part of the examination, the chest X-ray shows no cardiomegaly with oligemic lung fields. That being the scenario, exceptions to the described clinical features do occur as in all fields of medicine. Number 1. In TOF with polycythemia, especially when the TOF is seen untreated in adult life because of long-standing hypoxia, then no murmurs is heard in such patients. This is because the very high viscosity of blood prevents antegrade flow across the stenosed pulmonary valve even though the valve is not atretic. Such polycythemic patients of TOF with absent ESM of PS may be mistakenly diagnosed as pulmonary atresia. Now, palpable and loud S2, which is a hallmark of pulmonary hypertension, does not normally occur in conditions of decreased pulmonary blood flow. But in LTGA, the loud and palpable S2 occurs in second LICS because of the transposition of great vessels. In cyanosis with decreased pulmonary blood flow as in TOF, the precordium is usually quiet as indicated earlier. However, if there is PS with no VSD and right to left shunting across ASD, then RV pressure overload occurs due to the intact IVS producing a left parasternal heave and also cardiomegaly. So again in cyanosis with decreased pulmonary blood flow as in TOF, there is no cardiomegaly. However, exceptionally, cardiomegaly can be seen in TOF with complications such as anemia, hypertension, infective endocarditis and valvular regurgitation, myocarditis, post-surgical shunts. So now let's look into the chest X-ray in patients having cyanosis with decreased pulmonary blood flow. The chest X-ray will reflect the pathophysiology. Chest X-ray will not show cardiomegaly. The main pulmonary artery segment is absent in majority of cases because the MPA is hypoplastic with pulmonary stenosis. So consequently, the pulmonary bay is seen. The lungs show dark lung fields with stringy vessels because the pulmonary blood flow is so much decreased, it creates dark lung fields and small string-like pulmonary vessels. Further, if a right aortic arch is present, it is occurring in about 25% of TOF, and a left-sided aorta is often seen in LTGA. Again, in chest X-ray, exceptions do occur against generalization. Cardiomegaly occurs if there is no VSD and in associated MAP cause with increased collateral flow, and in TOF with absent pulmonary valve, cardiomegaly may occur. Contrarily, MPA may be prominent in PS with ASD and intact IVS, and also in TOF with absent pulmonary valve. This is a classical chest X-ray of TOF showing decreased pulmonary blood flow or pulmonary oligemia with dark lung fields. No cardiac enlargement. MPA is not prominent and the pulmonary bay is seen. More specifically, note the RV apex with boot-shaped heart. Enlarged aorta is seen along the right heart border because the deoxygenated blood gets diverted into the aorta instead of going completely to the lungs. So the aorta has double input from LV and also RV. Also check for right aortic arch by seeing the indentation on the right side of the distal tracheal air shadow. Now this is a chest X-ray of a cyanotic patient with decreased pulmonary blood flow, no cardiomegaly, absent main pulmonary artery. But note the prominent SVC, and more important, note the LV apex, which is suggestive of tricuspid atresia as the underlying diagnosis. Now let's come to the ECG. In cyanosis with decreased pulmonary blood flow, the ECG shows RVH in majority of cases. Now of these patients with RVH, most have right axis deviation as in TOF, DORV, TGA, single ventricle, pulmonary atresia. But in TOF, the right axis deviation usually does not exceed plus 150 degrees and the RVH is seen with early transition zone in V2. Now some patients with this RVH have left axis deviation as in AV canal defects, single ventricle, rarely in DORV and in LTGA. Rarely, instead of RVH, patients in this group of cyanosis with decreased pulmonary blood flow show LVH, as in tricuspid atresia, single ventricle certain types, hypoplastic RV and DORV certain types. This is a classical example of tetralogy of Fallot showing combination of RAD and RVH with the mean QRS axis around plus 110 degrees. RVH is seen with V1 showing a prominent R wave and V6 showing prominent S waves, indicating right ventricular hypertrophy. So to recapitulate, we are dealing with cyanotic heart disease with decreased pulmonary blood flow. Part A, we have finished Fallot's physiology, and in the same group, you have decreased pulmonary blood flow due to pulmonary artery hypertension, which is referred to as Eisenmenger physiology. Cyanosis with decreased pulmonary blood flow occurs late in large left to right shunt lesions. Because of chronically increased pulmonary blood flow, it leads to a pulmonary vascular obstructive disease and hence severe pulmonary arterial hypertension. This PAH reverses the initial left to right shunt now into right to left shunt, producing therefore finally decreased pulmonary blood flow and cyanosis, which is referred to as Eisenmenger physiology. Eisenmenger physiology is not confined to shunts in atrial, ventricular and pulmonary artery levels alone. Pulmonary vascular obstructive disease can occur very early in transposition physiology with increased pulmonary blood flow, that is without PS. So cyanosis in Eisenmenger physiology is not always late in life, though it is more commonly so. So Eisenmenger physiology is common to all patients of decreased pulmonary blood flow. Hence it occurs late on development of pulmonary artery hypertension in ASD, VSD, PDA, AP window and also in DORV, DTGA, TA, PVC. But all should have no pulmonary stenosis. Now let's go into the clinical features. The cyanotic patients with decreased pulmonary blood flow due to PAH, that is Eisenmenger's, have history of frequent respiratory infections in childhood due to initial significant left to right shunting. Now the cyanosis can occur earlier at birth or appears late. The JVP shows a prominent A wave. On inspection and palpation, one notices a marked parasternal impulse due to RVH and also a palpable P2. No cardiomegaly is obvious, except in right to left shunts at atrial level, which show cardiomegaly. Auscultation reveals a loud P2, which differentiates this group from cyanosis with decreased pulmonary blood flow with PS. Also, one hears the constant ejection click of PAH. There is disappearance of shunt and flow murmurs of left to right shunt. You can get an insignificant pulmonary systolic murmur may be heard or it is absent. PR and or TR murmur may be present. Now, among the Eisenmenger lesion, how to differentiate the common shunt lesions leading to Eisenmenger physiology? If one looks at the cyanosis, it is differential in PDA with PAH. In ASD with PAH patients, they show cardiomegaly and have prominent parasternal heave. Now, the S2 is more useful to differentiate amongst the shunt lesions in causing Eisenmenger because you get a wide fixed split of S2 in ASD. The S2 is single in VSD, whereas it is normally split in S2 in PDA. All have pulmonary hypertension with right to left shunt. Now TR is common in ASD with PAH. Chest X-ray would show a large ascending aorta in PDA with pulmonary artery hypertension. So how is the chest X-ray in Eisenmenger physiology? No cardiomegaly, but as an exception, cardiac enlargement does occur in ASD with PAH. Large hilar pulmonary arteries are seen. Typically, because of decreased pulmonary blood flow and PAH, the pulmonary vasculature shows cutoff beyond medial 1/3 of lung fields called as peripheral pruning, meaning the pulmonary vessels are seen prominent medially but not seen laterally in the periphery of lung fields. Now this is a chest X-ray in a typical case of Eisenmenger physiology showing no cardiomegaly, large hilar pulmonary arteries, peripheral pruning of the pulmonary vessels in the lung fields. What about the ECGs? The ECG is not very helpful to differentiate among the lesions. Because of pulmonary hypertension, the ECG shows RAD and RVH in almost all the patients in this group. So that specific diagnosis is often not possible with the ECG alone. Cyanotic heart disease with decreased pulmonary blood flow, but cardiomegaly and heart failure is another component of cyanosis with decreased pulmonary blood flow. Now, cyanotic heart disease with decreased pulmonary blood flow, but cardiomegaly and also heart failure occurs in two conditions such as EBSTEINS anomaly and in isolated PS with TR. The clinical features of EBSTEINS anomaly include quiet precardium, LV type of apical impulse. The heart size is very much enlarged, that is massive cardiomegaly. On auscultation, the S1 is normal. The S2 shows a wide split with variable P2, it being either normal or decreased. Third and fourth heart sounds are present. Mid-systolic click is also heard. All of these will produce multiple sounds. One also hears the scratchy ejection systolic murmur of TR at lower left sternal border and a scratchy MDM at the same area. This is a chest X-ray of patient having cyanosis with decreased pulmonary blood flow showing cardiomegaly. This is a case of EBSTEINS anomaly showing the marked cardiac enlargement called as box type heart. Here MPA is not prominent and an LV type of apical impulse is noted. This is a chest X-ray of another patient having cyanosis with decreased pulmonary blood flow with marked cardiomegaly. But this is a case of severe PS, pulmonary stenosis, with decreased pulmonary blood flow and right to left shunting across the ASD. Again, this shows the marked enlargement of the heart due to the tricuspid regurgitation. Here also the MPA is prominent due to the post-stenotic dilatation of pulmonary artery. There is no VSD, so RV pressure becomes very high. It produces RVH, severe high pressure TR and right atrial enlargement. This leads to marked cardiomegaly with RV apex and right to left shunt across the interatrial septum and hence cyanosis. Also, decreased pulmonary blood flow produces the dark lung fields. ECG of EBSTEINS anomaly shows right atrial enlargement, polyphasic QRS, no RVH, right bundle branch block and WPW syndromes can occur. An ECG of pulmonary stenosis with TR shows severe RVH and late transition unlike in TOF. Now, this is the second major group of cyanosis with increased pulmonary blood flow. Cyanosis with increased pulmonary blood flow is referred to as transposition physiology. Now, cyanosis with increased pulmonary blood flow basically means there is no pulmonary stenosis. If there is no PS, how does cyanosis occur? Almost all of these patients, except a few conditions, have transposed great vessels, meaning that the aorta arises from the right or venous ventricle and pulmonary artery from the left or arterial ventricle. So this abnormal connection and also mixing causes the cyanosis. Hence, this group of patients having cyanosis with increased pulmonary blood flow are commonly referred to as transposition physiology. Most important disease in this group of cyanosis with increased pulmonary blood flow is detransposition of great arteries with large VSD and no PS. In this group of patients, though there is an increased pulmonary blood flow, but because of abnormally related great vessels, they will also be cyanosed. Similar pathophysiology state also occurs in DORV VSD and no PS, truncus arteriosus, pulmonary atresia with MAPCAS and increased collateral flow, tricuspid atresia with a large VSD and no PS, and certain cases of single ventricle. Now, in cyanosis with increased pulmonary blood flow, only TAPVC patients have normally related great arteries. In TAPVC, the cyanosis is because all the oxygenated blood from the lung through the pulmonary veins is mixing abnormally with deoxygenated blood. Example in the right atrium in cardiac TAPVC, and this mixing causes cyanosis. So what are the symptoms? In cyanosis with increased pulmonary blood flow, the patients are symptomatic in the neonatal period itself. Contrastingly, the cyanosis can be mild to severe. Clinical recognition of cyanosis can be very difficult in this group of patients. Why is this so? Because of increased pulmonary blood flow, the cyanosis is not always prominent. Even if one is not able to detect cyanosis clinically, doing an oxygen saturation SpO2 will confirm the presence of cyanosis. This is because the majority of this group of cyanotic heart disease with great increased pulmonary blood flow, patients have transposition complex with abnormally related great vessels in spite of increased pulmonary blood flow. Again, because of increased pulmonary blood flow, these patients will have tachypnea, weight loss, and failure to thrive. Now, how will be the clinical examination of these patients with the increased pulmonary blood flow, that is, transposition physiology clinical features? These patients have hyperdynamic precordium, and cardiomegaly due to increased pulmonary blood flow appears within 2 weeks of life. Now, this is unlike the quiet precordium and normal heart size seen in cyanosis with decreased pulmonary blood flow. On auscultation, the second heart sound is single or sometimes split. Now, in cyanosis with increased pulmonary blood flow, S2 splitting will be present and the P2 is loud, but yet it is difficult to hear. Why? Because the transposed pulmonary artery is situated posteriorly and therefore one is not able to hear the splitting of S2. In cyanosis with decreased pulmonary blood flow with PS, it is the difficulty to hear the splitting because it is very soft due to severe pulmonary stenosis. So ultimately, putting all together, basically in both groups of cyanosis with decreased pulmonary blood flow and in increased pulmonary blood flow, there will be a single second sound in second LICS. S3 gallop may be heard. They may have only a short, insignificant grade 1 to 2 ejection systolic murmur at the base. Unlike those with decreased pulmonary blood flow, these patients with increased pulmonary blood flow have flow murmurs, now which is a mid-diastolic flow murmur at the apex. Flow murmur is due to the increased pulmonary blood flow which returns from lungs to the left atrium and flows torrentially across the mitral valve into LV in diastole, causing this MS-like MDM at apex, though actually there is no real MS. Sometimes one may hear a diastolic murmur in second left intercostal space due to regurgitation across semilunar valves, and if heard, it typically occurs in truncus arteriosus. In this group of patients, there is no continuous murmur. Why? Because the pulmonary artery pressures are in higher range in this group of patients with increased pulmonary blood flow. Chest X-ray shows cardiomegaly with pulmonary plethora. So the chest X-ray in this group of transposition complex also reflects the pathophysiology. It will show cardiomegaly. The increased pulmonary blood flow is called as plethoric lung fields. In cyanosis with decreased pulmonary blood flow, the pulmonary artery segment is not seen because it is small. In increased pulmonary blood flow, also the pulmonary artery segment is not seen because of transposition and the pulmonary artery lying posteriorly. However, in one group of these patients, pulmonary artery will be prominent, namely in TAPVC without a transposition. Further, some of these patients have right aortic arch. In a patient with increased pulmonary blood flow, if there is a right aortic arch, it most commonly indicates truncus arteriosus. So this is a chest X-ray comparison. In cyanosis with decreased pulmonary blood flow with VSD and PS, as in tetralogy of Fallot, there is no cardiomegaly, dark oligemic lung fields due to the decreased pulmonary blood flow, and the MPA segment is absent with concavity, namely the pulmonary bay is seen because of the small and hypoplastic pulmonary artery due to PS. On the other hand, in cyanosis with increased pulmonary blood flow, the chest X-ray shows cardiomegaly, and there is a white plethoric lung fields due to increased pulmonary blood flow. Again, here also the MPA segment is not seen because the PA is posteriorly located due to transposition of great vessels and described as having a narrow pedicle. This gives an egg-on-side appearance occurring in DTGA with the VSD and no PS. Now, this is another classical example of a chest X-ray of a patient with cyanosis with increased pulmonary blood flow. Now this is an exception to the rule. It occurs in supracardiac TAPVC, wherein the great vessels are normally related unlike others in this transposition group. Now one can identify the vertical vein draining the confluence of pulmonary veins, then through the innominate vein and a dilated SVC, the blood goes into the right atrium, and then through the atrial septal defect, there is a right to left shunt from RA to LA. So now in this supracardiac type of TAPVC, there is cardiac enlargement, increased pulmonary vascular markings, but unlike others in this group of cyanosis with increased pulmonary blood flow with transposition, here the MPA segment is prominent since the great vessels are normally related and PA is as normally anterior. This appearance is called as the figure of 8 or the snowman appearance or the cottage loaf appearance. Now let's come to the electrocardiogram. In cyanosis with increased pulmonary blood flow, one sees biventricular hypertrophy due to increased flow into the left-sided circulation also through the large VSD. The ECG is not very contributory in cyanosis with increased pulmonary blood flow. QRS axis deviation will be similar in increased pulmonary blood flow with and without cyanosis. For example, a patient with VSD with left to right shunt and the same patient when in cyanosis with right to left shunt will both show similar biventricular hypertrophy. Typical ECG showing biventricular hypertrophy with tall R wave in V1, large equiphasic QRS and V3, V4, V5 called as Katz-Wachtel phenomenon indicating biventricular hypertrophy. So ECG is not very contributory in cyanosis with increased pulmonary blood flow because they follow a uniform pattern in all the groups. And finally, to complete the third group of cyanosis with normal pulmonary blood flow. This group consists of two conditions, namely pulmonary AV fistula and a much rarer condition of left SVC draining to left atrium. In pulmonary AV fistula, cyanosis occurs because the pulmonary artery deoxygenated blood gets directly shunted into the pulmonary veins in the lungs, bypassing the pulmonary capillaries and hence without undergoing oxygenation, and thus reaching the left atrium and systemic circulation directly, producing cyanosis. Since the arterial and venous connection occurs directly, bypassing the lungs, it is called as a fistula. In LSVC to LA, cyanosis is understandable because the deoxygenated blood in the left SVC, instead of reaching the right atrium and entering pulmonary circulation for oxygenation, now abnormally directly drains into left atrium and produces cyanosis. Clinically, in both these conditions, the patients have typical clinical features. That is, a normal cardiac examination, meaning these patients have a quiet precardium, no cardiomegaly, normally split S2 always, and no murmurs in the precardium. That means, again, one emphasizing that the cardiac examination is normal. Rarely in pulmonary AV fistula, one can hear continuous murmurs in the periphery of lung fields but not in the precardium. The chest X-ray may help in diagnosis. In LSVC to LA, the chest X-ray is always normal. But in pulmonary AV fistula, peripheral lung fields may show patchy shadows. ECG is normal in this group of cyanosis with normal pulmonary blood flow. By itself, the chest X-ray is not diagnostic. So if you see a chest X-ray in pulmonary AV fistula, this one shows shadows in the left lower lung field. Now, cyanosis with normal cardiac findings and a continuous murmur in peripheral lung fields and having this chest X-ray, then taking all in combination, one can diagnose pulmonary AV fistula, especially when we do an echocardiogram and you find that the echocardiogram does not show any obvious structural heart disease, which is diagnostic of pulmonary AV fistula. Cyanosis with the echocardiography showing normal echocardiogram, and one can think of pulmonary AV fistula. So now you have cyanosis in a patient and there is no murmur and he is surviving to adult life. So you are surprised and really surprised, because it is often due to the unusual causes of cyanosis, as we already mentioned: pulmonary AV fistula, left SVC to LA, and also IVC draining to LA and the right SVC draining to LA. There is yet another approach. This is grouping the cyanotic congenital heart disease according to the murmurs. Now, if there is a patient with cyanotic heart disease with pansystolic murmur, it can be due to associated ventricular septal defect or due to MR or TR. Now, if it is due to ventricular septal defect, this VSD must be obligatory. That is, it is the only exit for the blood from left ventricle. This occurs in two conditions: one, tricuspid atresia, and two, double outlet right ventricle with small restrictive VSD, which is uncommon. Now, differentiation can be done by the ECG. In tricuspid atresia, ECG shows LV dominance, whereas in double outlet right ventricle, the ECG shows RVH. So again, the cyanotic congenital heart disease with pansystolic murmur can be due to MR or TR, and this occurs in AV canal defect, that is endocardial cushion defect with PS or Down syndrome, or in severe pulmonary artery hypertension. It can also be seen in EBSTEINS anomaly of tricuspid valve, severe isolated PS with TR, ASD severe PH with TR, and also in LTGA ventricular septal defect with PS with EBSTEINS anomaly of the tricuspid valve. On the other hand, if you have a cyanotic congenital heart disease patient with continuous murmur, this indicates that the PA pressure is low and it occurs in certain conditions. The number one and foremost condition to be almost always entertained is pulmonary atresia with ventricular septal defect. Herein, the continuous murmur is due to MAPCAS or associated PDA. It can also occur in TOF with PDA, supracardiac type of TAPVC, pulmonary AV fistula where the continuous murmur is more into the lung fields, surgically created shunts, BT shunt, POTS, Waterston and central shunt, and also in peripheral pulmonary stenosis with right to left shunt across ASD, VSD or PDA. These are the conditions where you can get a continuous murmur associated with cyanosis. Now another case could be there with the cyanotic congenital heart disease with a to and fro murmur, and this occurs in TOF with AR, also in truncus arteriosus with truncal regurgitation, and in an absent pulmonary valve patient. Now, echocardiography. Echocardiography has revolutionized pediatric cardiology. The role of echo in pediatric cardiology is, it is the mainstay in final confirmation of diagnosis. It gives you an exact anatomical diagnosis, helps in physiological classification, whether there is PS or no PS. More importantly, it gives hemodynamic information, PA pressure, etc., helps to assess the ventricular function, and above all, it helps to decide the type of repair needed. Now, this pediatric echocardiography must be performed by skilled personnel since errors are possible. So, provisional diagnosis must be made based on clinical examination, chest X-ray and ECG, and further confirmed with echocardiography. To conclude, key to clinical diagnosis: work in order. Check the pulses, the jugular venous pulse as well as the arterial pulse. Color, observe for cyanosis, pallor or polycythemia. Inspect for chest form and pulsations. Palpate to determine which ventricle. Is there pulmonary hypertension and what would be the pulmonary blood flow? Forget the murmur. Listen first to the first heart sound and then to the second heart sound. Can you split the second sound? Then concentrate on its components. Finally, the murmur and its location: systolic, ejection, pansystolic, continuous. And observe and note, is there a continuous diastolic murmur? Another key to clinical diagnosis. Bedside precise anatomic diagnosis is not always possible. Have a systematic approach with history, physical examination and categorized into pathophysiological groups. Overall approach is that there are three main pathophysiologies in cyanotic congenital heart disease. 1. Fallot's physiology. 2. Eisenmenger physiology, both of which are associated with decreased pulmonary blood flow. And last but not the least, third, transposition physiology associated with increased pulmonary blood flow. Assess whether the patient has a life-threatening condition immediately. Example, a deeply blue child, severe respiratory distress or shock indicating a PDA dependent circulation. The problems in clinical diagnosis occurs because of the neonates have a fast heart rates and changing physiology, and polycythemia could mask the murmurs. Infants with heart failure, then it is usually cyanotic congenital heart disease with increased pulmonary blood flow. Once more emphasizing, if you find neonate with congenital heart disease cyanosis with shock, it is a ductus dependent congenital heart disease. In older children and in infants with cyanosis, consider TOF or its variant. In the absence of heart failure, I have found out by finding that the chest X-ray and clinical examination shows a normal sized heart with pulmonary oligemia on the chest X-ray. Echocardiography, once again emphasizing, should be performed as early as possible since it exposes loopholes in clinical diagnosis. Further aid in clinical diagnosis are certain axioms. If a cyanotic heart disease child over 2 years is admitted in ward and if it is diagnosed as TOF, it is 75% of the times correct. This is called as Nada's dictum. If a patient is having cyanosis with normal sized heart or near normal sized heart and oligemic lung fields, it is definitely tetralogy of Fallot. This is Taussig's axiom. Note, in every 15 minutes, a baby is born with congenital heart defect. In cyanotic heart disease, the best diagnostic approach is early echocardiography and should not be delayed. And thus we conclude the approach to cyanotic congenital heart disease. And thank you for your valuable time.